lectures. It's all good. We're gonna review. We're gonna review some of those, the important ones that I want you all to get down. Okay. So we'll start with lecture 3, which is that last chemistry. Okay. We had talked about nephrotic versus nephritic syndrome. Y'all remember the difference?
Nephrotic is protein, nephritic is blood.
Okay. What test on the blood side would you run? Make someone have nephritic. Let's start with BMP. What specifically would you be looking at? Bacteria. What about in the CMP? We look for BUN. Maybe see it elevate creatinine. And then as far as urine, what kind of cast would you see?
No, the oval bodies.
What else? Red blood cell counts, okay? Red blood cell counts. All right, so if you have a patient and you know that they're diabetic, right, and you run a BMP on them and their glucose is low, what is that telling you?
Too much insulin.
All right, so you have a patient that is vomiting, got fatigue, muscle cramps, right? And then you run a BMP and you see that her BUN is high, sodium is high, chloride is high, BUN creatinine, osmolality, and urine osmolality is high. Yeah, dehydration or kidney dysfunction, okay? All right. Our liver panels, what are some tests we find on liver panels? ALT, ALP, and bilirubin. Okay. Good. And a decreased albumin would tell you what?
A decrease?
Yeah,
Liver
something's going on with the liver, right? You probably need to do some follow-up. Okay. What about pre-albumin levels? Those are low. What do you think? The old man, he's got weight loss, he's not eating very well.
Dehydration.
Nutritional.
Nutritional status.
You need to do nutritional assessment. All right. What is that sensitive marker for early kidney dysfunction? It's on that slide that has the creatinine test on it. And then creatinine. It's in the words. Sorry.
Yeah, C. That's the
Dissect C. All right, so y'all remember we talked about arterioblic acids. When we think of somebody that's fully compensated metabolic acidosis, their pH is what? Normal. The bicarbonate is elevated, and that would indicate a metabolic alkalosis. Right? So there's going to be a couple of arterioblic acid channels. Okay, so make sure that you're understanding. A partially compensated metabolic acidosis would be the pH would be abnormal. An uncompensated metabolic acidosis would be you have a case where the partial CO2 or bicarbonate are normal. Okay? So just make sure you get those down. Yes, sir.
Can you use the microphone, please?
Oh, okay, absolutely.
Just having trouble.
Can you hear me? Oh, you gotta put the battery in. See, I'm slow today. I got up too damn early. Y'all need to get me on that Friday afternoon. That's when I'm mostly late. It is. All right. Good to go? All right, so remember that slide that had the acid, base, and balanced gases, and the slide that had the Rome, right, where it distinguished the respiratory from metabolic. Make sure you're getting that down because there are a couple of questions on that, okay? So that's lecture 3, right? Lecture 4. All right. Okay, so you have a female, she has severe epigastric pain and vomiting, and her amylase is high. What is your next confirmatory test? Lipase, serum lipase would be your next test, right? And what would you be diagnosing? Acute pancreatitis, correct. All right, so we talked a little bit about people with diabetes, right? And there's about 3 different ways that you can monitor diabetes. What's one of them? What? Hemoglobin A1C, and that measures what?
Long
The
term.
long term, right? A 3-month, right? What's another way?
Fasting glucose.
Glucose, and that is with point of care, right? Then we have that finger stick, right? That's also with point of care. And then what's that other one? Yeah, and what fluid does that test? Interstitial fluid. Y'all gonna kill this test. Y'all gonna do so good. Okay. I think I had to ask you about this. What is autoimmune B cell destruction
Type 1. Type 1 diabetes.
for type 1 diabetes? When we see B cell dysfunction, what are we looking for? Type 2 diabetes. We already talked about hemoglobin A1C. Okay. Now, if you suspect the patient is in heart failure, what cardiac test would you run? What? Troponin's 1, BNP, myoglobin, and CKMB. And out of those cardiac tests, which one's going to be severely elevated? The BNP. Troponin can be, but for the sake of this test, okay? So, what is that test that an elevated NPO level that correlates with what? So if you have an elevated MPO level, this is in lecture 4, specifically on slide 16.
Plaque instability.
Yes, increased plaque instability. Very, very good. Yes, on the slides, that's right. So if you have a patient with a liver injury, what would their liver panels look like? So an increased ALT, an increasing AST. If they have a biliary obstruction, what would those liver panels look like? Okay, that's one. ALP will be elevated, and then GGT will be elevated, right? An impaired liver synthesis. So decreased albumin and total protein. Good. Okay. Lecture 5. All right, remember we talked about the thyroid panels? What are those 3 tests that you would see on a thyroid panel? That's lipid.
TSH.
So lipid panel, let's go. Lipid panel is what? Total cholesterol, LDL, HDL, VLDL, right? And in lipid panels, we're mostly just looking dietary, people who got diabetes, things like that, okay? Now, thyroid, what are the 3 that we're looking for? TSH, free T4, and T3. Good. Now, if you suspect that someone has hyperthyroidism, what is that disease state? Graves' disease. And what is that antibody that's specific for Graves' disease? Lecture 5, slide 25. Yeah, TR antibody. Okay. All right, someone that's at increased risk for cardiovascular disease, what levels would be elevated on that lipid panel? LDL. What else? Y'all quiet on this side of the room. What's up?
Low LDL,
Whoa.
low HDL,
He's like, what?
I've answered.
low HDL.
LDL would be good. Triglycerides, total cholesterol. Okay. All right, and you see that in cardiovascular disease. I'm not trying to hurt my feelings, man. I just want y'all to participate. That's all. That's all. Okay. We talked about your risk heart disease. Okay. So lecture 5, slide 17. What are some other assays that assess the risk of chronic heart disease?
That's a long word to say.
Yeah, some lipoproteins, right? Well, which one is specific, is that the best marker for chronic heart disease out of those lipoproteins? Which one of them?
B.
The B-100, correct. Correct. Okay. So in primary hyperthyroidism, those, what would be high and what would be low in that? Okay, so in primary hyperthyroidism, it would be a low TSH and a high T4, okay? It's okay. Secondary hypothyroidism, what would that look like? Secondary hypothyroidism. Yeah, TSH is low, the T4 would be low, okay? And then that secondary hyperthyroidism, high TSH, high T4, yeah. Just make sure you're understanding the difference between that primary and secondary hyperthyroidism, hypothyroidism, okay? There's a couple of questions off of those, okay? Talked about Graves' disease and that antibody, okay? So that was all the lectures we went over last week. Unless y'all wanna hit 1 and 2 again, it's really up to you all. You want 1 and 2 again, okay, cool. All right. 1. All right, so remember we talked about UTIs, okay? And so what would you see in UTIs?
Protein.
Yeah, so you see bacteria, some protein, yeah, maybe some red blood cells. And under the microscopic, what would we see? Dysmorphic RBCs. What else? White blood cell casts, yeah. Okay, maybe a little mucus, or a lot of mucus, I should say, not a little bit, a lot of mucus. But mucus is not diagnostic of anything. It's just something that accompanies UTI. So I just want y'all to be clear about that, okay? All right. What is the best test that you would use for a 24-hour urine is what? What are we looking for? Yeah, we're looking for kidney function, but what is the primary purpose of a 24-hour urine? Yeah, it measures the total amount of various substances. This is a quantitative assessment. Okay. So what is the best step to evaluate a tubular reabsorption? Yeah, evaluate a tubular reabsorption, you would do a normal fasting blood glucose. Okay. Right. Diabetes insipidus, what can you tell me about it?
Low polyphasic gravity. There's brain version and kidney version.
Yeah, there is. Okay, and what's that? Neurogenic or nephrogenic? Correct. And what's the difference between the two?
You give them ADH, you give them ADH, and
Neurogenic will respond, or the
the
neurogenic
neurogenic will respond.
Nephro will not.
Correct. Yep.
Yeah, look, those.
Y'all got that. All right. What is the, all Alright, so if we see a significance of osmolality, if we see a high osmolality, what are you thinking? What are conditions are associated with that? Dehydration, reduced fluid intake, sweating, fever, vomiting, diarrhea, okay? And then y'all already explained the neurogenic versus nephrogenic. Good. Okay, so if you have a patient, you want them to submit a morning voided sample, but it gets rejected from the lab, what would be the reason?
Dirty.
It's dirty. And why is it dirty?
They didn't do a clean catch.
There's a whole bunch of squamous epithelial cells up in there. We don't like those. Well, I like them, but we don't like them in the UA bench, okay? All right, so if you have a patient with hepatocellular jaundice, what would those labs look like?
A bunch of unconjugated.
What else? Those ALT and AST, they'll be what? Elevated or decreased? Elevated. And your total and indirect bilirubin will be elevated as well. All right, so what's the difference between a bacterial infection in a urine versus a non-bacterial infection?
Then nitrites.
Nitrites. All right, that's one. All right, lecture 2. Okay, what are those crystals or whatever starts with an S that are found with kidney stones? Calcium phosphate crystals, and those struvite calculi. Okay, that's another term that's used on this test for those. We talked about rejection. All right, and renal tubular damage, what would we see under the microscope?
Protein.
You can't really see protein necessarily. What kind of cells? No, not protein cells. In renal tubular damage, microscopically, what will we see?
RTs.
Renal tubular epithelial cells. What kind of cast?
Fat box. Red blood cell. Highland.
Granular.
Granular cast. All right, this side of the room. Cool. All right. Yes, and just as you had stated, Highland cast does not necessarily mean there's anything going on with that patient, all right? As long as it's less than 3 per high power field, there's no apparent pathology, okay? All right, so if you have somebody that has, in their urinalysis, the dysmorphic RBCs and RBC casts, now what are you thinking? The protein is high. Yeah, glomerular damage or nephritis, correct. All right, what does, in a urinalysis, what does end-stage renal disease, what would present on those labs?
Broadcast.
Broadcast? What about blood? Protein? Yeah, all those things, right? Okay. We talked about, okay, so what is another crystal that's found in UTIs? They're thorn apple spiky looking crystals.
Ammonium biurate.
Ammonium biurate crystals. Right. That's stepping up. I love it. All right, urethritis in urine. What would that look like under the microscope? Doesn't affect you, right? So you see mucus, white blood cells, bacteria. Okay, very similar to UTIs. But in a urethritis, you would have a whole bunch of mucus like everywhere, to the point where the laboratory wouldn't be able to count it, okay? So that's the difference. All right, and what is retrograde ejaculation?
Sperm backwards into the bladder.
And on the microscopic, what would the sperm, would they be small or would they be large? They're large. Large sperm. Okay. Yep, large sperm. Okay.
Larger mounts.
Larger mounts.
Large. I don't know, what's it specific to say, because I have a large one.
Large mounts.
Okay, large amounts.
Polyprotein.
Yeah, okay, so then that just means it's a whole bunch of sperm everywhere on that slide. Okay. That was a quick, 20-minute review. How y'all feeling?
I'm good right now.
Solid.
Feel better? Good?
Be good by
Thumbs up on
Friday.
this side?
Yeah.
Can I get some? Okay, good. Y'all look at me like, whatever. Okay, so I will see y'all Friday morning. Y'all gonna rock it, okay?